the sense that it will represent the function, and the changes in the histological layers or the structures will be represented as histopathology, and that's where you treat those structures or the changes in those structures, so that becomes your pharmacology. So this is basically, when you read histology, I always urge students to, especially in systemic blocks, to keep the histopathology side by side and pharmacology side by side. By the end of the lecture, I will tell you how to do it. So our learning outcomes for this class is, you would be able to classify the respiratory tract and describe the microscopic features of all these structures, nasal cavity, pharynx, larynx, trachea, bronchus, lung, and pleura. You will describe the blood gas barrier, and also you will relate the histology of these structures with the respective clinical conditions. Without any clinically correlation, histology also doesn't hold good. So always we should be able to correlate with clinical cases. Don't compartmentalize your mind like this is going to be like this, or I mean, it's separate. Gross is separate, histo separate, histopatho is separate. No, everything is together. Okay. So how do you classify the respiratory tract? We classify it as a conducting portion and respiratory portion. So the conducting portion, the function is it should deliver the air to the respiratory tissue. It is like, for example, I am sitting outside my house. So when I'm sitting outside my house, the temperature outside is around 37, but my body temperature might be 35. So I would take air of about temperature 37, convert it to 35, so it will humidify or it warms accordingly. Either it reduces the temperature or it increases the temperature. For example, aircon in our lecture halls are very cold. So whenever you breathe, you will breathe air which has a temperature around 23 or 24, something like that, but you will convert it to 35 or 36 according to your body temperature, and then it will pass down. So the conducting portion doesn't just transmit, it will warm the air, it will humidify the air and clean the air as it passes down. So for air to pass through, you cannot have collapsible walls. You have to have rigid walls, because the airway should already be open. If the walls collapse, the patient dies. So coming to the respiratory portion, this is responsible for exchange of gases between air and blood. So the contact area between air and blood should be very thin. So that's why we have collapsible walls in the respiratory portion, because we need to maximize the contact between the blood capillary, which has carbon dioxide, and the air, which has oxygen, and gaseous exchange takes place. Am I clear?
Yes, doctor.
Okay, yeah. So I'm continuing. So what are the conducting zones and what are the respiratory zones? The conducting zones has two things, one in the airways, second in the lung. In the airways, of course, the nose or the nasal cavity plus the paranasal sinuses. Number two is the pharynx. Pharynx is considered a portion of the gastrointestinal tract. Only the naso and the laryngopharynx will be a part of the respiratory tract. So more about the pharynx we will talk in the GIT. Larynx is otherwise known as the voice box. So this conducts your air. The air then passes into the trachea. From the trachea it goes to the primary bronchus. Once the primary bronchus divides into smaller bronchi or secondary bronchus, we call it as secondary or tertiary bronchi, that enters the lung. So those along with the bronchioles and terminal bronchioles will form the conducting zone of the lung. So up to this level, the wall should be kept rigid for air to reach through. Once it goes beyond terminal bronchioles, it forms respiratory bronchioles, alveolar duct, alveolar sacs, and alveoli. So here the walls become collapsible so that the gaseous exchange can take place. Just look at the figure above. So for trachea, bronchi, and bronchioles, you can see the wall is very rigid. When you go to the respiratory, alveolar duct, alveolar sac, the walls become very collapsible and very thin so that gaseous exchange can take place. So the histological structure of these organs basically depend upon their functions. So what's the function of? So first I'm going to the conducting portion. So it conditions the inspired air. So mucus is a very important conditioner. Mucus is what we call it as hingus, or the whitish secretion that comes from the nose. So this mucus is a normal component of our body. Only when we have a flu, automatically we will stimulate the mast cells to secrete more histamine, so that can stimulate the mucus cells, the goblet cells and the glands to produce more mucus, because we want to shed away or remove away the virus or the pathogen which is irritating us. Similarly, people have allergy when they get up in the morning. When they get up in the morning, the moment the dust enters the nose, or the pollen enters the nose, we get allergic problems. We start having running nose. Why we have running nose? Especially during my PBL who got, Daniel Lukman had running nose due to allergy. I was scared it was due to COVID. Okay. So when we have these allergic conditions, our body will tell to remove that allergen from the nose. How do you remove? With mucus. So this mucus is basically present to condition the air in the nose. It performs the function of sun silk conditioner in the nose. So if mucus is there in the nose, we need something to move or propel the mucus. So we have cilia in the nose to propel the mucus to the pharynx. So whatever secretions in the nose, the cilia will beat to bring it to the oral cavity. That's why always we tend to take in the mucus and spit it outside. If it is excessive mucus only, we bring it through the nose. Otherwise, the normal mucus will propel through the oral cavity. Nose is also used for the smelling, so it is also used for olfaction. So phonation and olfaction depends upon air movement. What do you mean by phonation and what do you mean by olfaction?
Phonation is producing
Olfaction.
sound.
Yeah.
Your voice.
Voice la. Olfaction?
Smell.
Smell. So whenever we have a flu, our voice is not good. We speak with a nasal tone and our smell is also not good. We don't smell anything because the nose is blocked. This is because the conducting portion is totally engorged, so the normal function of phonation and olfaction does not happen. So this is the function of all your conducting portions. So based on this, let's go to our nasal cavity first. Nasal cavity, yeah, we said it has to filter the air. So whatever the open or the external nares, N-A-R-E-S, nares, what we see outside is called as the vestibule of the nose. That is considered the anterior most portion of the nose. We can see our external nares. So when we go and see ourselves the external nares, we see hairs. Whenever we have hair, it is actually a thin skin, so you will have sebaceous glands, you will also have sweat glands. These are basically for our protection. So mostly when it's very heaty or when we have an infection, we end up having boils in the anterior nares because of the infection of these sebaceous glands. The whole part of the nasal cavity which is not visible to our naked eye is called as the posterior portion. Of this posterior portion, we again divide it into anteriormost Kieselbach area, then nasal fossa and olfactory region. What is Kieselbach area? I think Dr. Atika would have touched this up for
It's
you.
where the area of all the anastomosis of the
Yeah. So
arteries of the nose.
whenever we have large arterial and venous plexuses, this is also a very nice point to humidify your air. So this Kieselbach area is the common area for epistaxis. What is epistaxis?
Bleeding.
Bleeding from the nose. So bleeding from the nose is usually due to the from the Kieselbach or the anteriormost area. The end of the nasal cavity, you still have a lot of blood vessels, and bleeding from there is very common in hypertensives, and that is an emergency. So when a patient comes with epistaxis, we have to determine whether it comes from the Kieselbach area or deep inside the nasal cavity, because the the cause of the bleeding differs. So once we go from the Kieselbach area, in this picture, the whole blue area, we call it as the nasal fossa. So this nasal fossa has the concave. What is the concave?
It's the three small bones of the nose.
Yeah, so of which only the inferior concha is a separate bone, the superior and the middle are parts of your ethmoid bone. So you will have three small bones which make the travel of the air inside the nose very tricky. It's like traveling through a maze, because more the contact the air has with the nose, the more it gets cleaned, the more it gets warmed, the more it gets humidified. So if it directly passes, you see in this figure, it directly passes from the nares to the green area behind. So there is no chance of it to being conditioned well. If you have concha, it passes through the concha up and down, up and down. So automatically it will be cleaned and humidified very well. The roof of the nasal cavity is where you have the olfactory region. Why is it in the roof?
Because your olfactory nerves, I think, from the ethmoid bone can come in
Yeah,
contact.
so I've put my cursor onto the cribriform plate of ethmoid bone. So whatever sensation or olfaction you smell through your nose goes directly through the cribriform plate of ethmoid bone and directly enters your brain. Olfaction is the only sense that, or the sensation that passes through to the brain without passing the thalamus. All other sensation have to put an attendance to the thalamus first and then only go to the brain here, or the cortex. Here only olfaction is actually, it is directly entering the brain. That's why loss of olfaction in elderly people can be a sign of dementia, can be Alzheimer's or neurodegenerative disorders. So whenever, and they will not say I don't have loss of smell, they will say I have a loss of taste. For taste to be very good, you should have a good sense of smell. So that's why in flu you don't feel any taste, because you lose your smell, not your taste actually. So the first sign of Alzheimer's disease, neurodegenerative disorders, is where you have loss of smell. Even in COVID, they have loss of smell and loss of taste, right? They have anosmia and ageusia. Have you read about COVID? Yes, no? No,
Not too detailed.
Oh, you have to, lah. Aren't you? I think people will be bombarding all of you with COVID questions because you're medical students, lah. I think they are bombarding me, lah. My friends are asking, who are non-medical people, asking me thousands of questions. Just to answer them, I have to read. So now let's go to the detailed histological structure. So now we are just concentrating on the nasal fossa. So all organs of the respiratory system is made up of three layers. We have mucosa. Beneath the mucosa, we have submucosa, and then we have serosa or adventitia, whether it is a supporting structure or a secretory structure. Only the GIT or the pharynx will have four layers. It will have an extra muscular layer because it has to propel the food downwards. So when we go to the pharynx, only we will be able to see four layers. Otherwise, the respiratory system is just made up of three layers. Number one is the mucosa. So when air passes through, it will come into contact with the lining epithelium. The epithelium is supported by the proper layer, or what we call it as lamina propria. Beneath that, we have submucosa filled with glands and nerve plexuses, and then the last one is your connective tissue. This is standard. Depending on the area and function, this will keep on changing, okay? So the nasal fossa, the mucosa, is the respiratory epithelium. Respiratory epithelium doesn't change for the conducting portion. It is pseudostratified with cilia, so I call it ciliated columnar epithelium with goblet cells. What do you mean by pseudostratified?
It looks like there's many layers,
Feels
but
finger.
So if you
look,
see in this picture below, you can see that the nuclei of the cells are at different levels. So I might think it is layered, okay? I might think it is stratified, but it is not stratified, but is pseudostratified. All the cells will rest on the basement membrane. So beneath that, beneath the epithelium, you can see blood vessels, mucus glands, lymphatic nodules, and rich vascular plexus. Why do you have lymphatic nodules?
immune response.
Yes, your nasal cavity and oral cavity are exposed to the outer area. So whatever you eat or whatever you breathe, you have bacteria, virus, foreign bodies, everything going in. So your body should give an immediate immune response at that level itself. That's why you have a lot of mucus, serous, lymphatic nodules and vascular plexuses. So these secretions from these glands will keep the epithelium moist. You can see it is made up of a lot of and lysozymes. So once the bacteria enters, the first level defense starts in your nose itself. The vascular plexuses are used to warm the inspired air. That's why in Kiesel back area you have a lot of vascular plexuses to warm the inspired air. And the lymphatic nodules, mast cells and plasma cells, they are protective in function. So once air enters, it will go through the pseudostratified ciliated columnar cells. Then it will be cooled down by the secretions of the glands. The vascular plexus will actually make it equivalent to your body temperature, and if there is any bacteria or virus, your lymphatic nodules will act on them. So when I say pseudostratified ciliated columnar epithelium, that means I have different types of cells. That's why they are of different height. So the most common cells are ciliated columnar cells. What is the function of cilia?
For movement.
So it is just moves whatever structure is there on the top surface. So now my cursor is actually sitting on the cilia. So if there is mucus or there is a lot of secretions there, the cilia will beat towards one direction. What is the function of microvilli?
Absorption.
Increase absorption.
Yeah, so for your GIT, it is going to be microvilli. Whatever you eat, you're supposed to absorb that. So that is why you have microvilli. So the most common cells I see in the respiratory epithelium is the ciliated cells. Number 2 will be the goblet cell. So what's the function of goblet cell? Produces
Mucus secretion.
mucus. So now I'm putting my cursor on the goblet cell. It is that greenish color cell which appears like a wine goblet. It looks like a wine glass. Because the nucleus is pushed down, the heavier secretion are pushed up. So then the other three types of cells, I've put it in red, brush, basal and granule cells. They do not make the majority, but they are still there. Brush cells are columnar cells with microvilli, very minimal microvilli. They are general sensory function. So if you pick on your nose, if something painful happens, the sensation is carried by the brush cells. These microvilli are not absorbent, but they carry the general sensation. They are not for absorptive function, they are carrying the general sensation function. To replenish these cells, I need basal cells or stem cells. So these are the cells which sit on the base, the small cells that sit on the basement membrane. They don't reach up to the lumen. Once these cells die above, these will replenish to form either ciliated cell or goblet cell or brush cell depending on the function. The last cell is actually the granule cell. Granule cell is very special because it comes from the neural crest cells. So this granule cells, this has many cytoplasmic granule. They are called as neuroepithelial cells, meaning you stimulate a granule cell, it will produce a lot of secretion and directly it will go and stimulate the nerve endings actually. So it's actually stimulated by neuronal nerve endings and it produces an epithelial function of secretion. So whatever it produces, it can either increase the vascular caliber, decrease the vascular caliber, tell the goblet cells to secrete more mucus or not. So granule cells are quite very little, but their function is a lot. They call it as APUD cells, APUD. It is called as amine precarboxylase. No. Amine, I forgot the name word. Uptake decarboxylase. Amine precursor uptake decarboxylase cells. Okay, or the other name for it is called as Kulczycki cells. I will talk about it more in the trachea. So since you have different cells of different function and different sizes, the epithelium looks pseudostratified, ciliated columnar epithelium. Clear? Can I continue?
Yes.
Okay. So now I'm going to the lateral wall of the nasal cavity. So this is your normal nasal fossa, what we saw. Now I'm going to the area where the conchae or the bones are present. So the lateral wall has got three conchae, which are again lined by your respiratory epithelium. The lamina propria has the same venous plexuses. I just want to concentrate on the figure where I call it as cavernous bodies. So cavernous bodies are the venous plexuses or that swell alternately to regulate airflow. So it will actually, at one time you actually basically use only one nostril to breathe. Have you ever seen that always sometime one nostril is closed, and they usually in yoga classes they will tell us to try to breathe through both the nostrils alternatively, because these cavernous bodies will swell up and they will not allow the air to pass through one nostril. They will allow one to pass through, then the other to pass through. So these venous plexuses are very, very essential because they will allow the epithelium to recover from desiccation. So whenever we have a flu or whenever we have a allergic reaction, number one, we will have more secretions. Number two, these cavernous bodies will swell up a lot. When they swell up, they will completely block your nasal passage. That is what we experience as nasal blockage. So the moment we have nasal blockage, we run to pharmacy to get what drug? Nasal decongestant, right?
Phenylephrine.
Yes, you get, or we call it as Afrin. Afrin nasal drops is very famous in this country. So this is called as oxymetazoline or xylometazoline. So the moment you put these nasal drops, it will reduce the secretions or the filling of this cavernous body. So your nasal blockade will get relieved. So allergic reactions and in your flu, there is a lot of blood pouring into these cavernous bodies, so it will swell up the concha so much so that automatically the nose goes for blockade, and that's why you give nasal decongestants to relieve it. So when I look at a lateral wall of nasal cavity, I can see the respiratory epithelium. I can see a lot of cavernous bodies there in the lamina propria, and then I will see the bone which forms the concha. So here this is very essential to know, because why you give nasal decongestion is to combat your cavernous body swellings. So when I look at the respiratory epithelium, so this is just two stains which shows the respiratory epithelium. My cursor is on the lumen of the nasal cavity. Can you see the lumen of the nasal cavity at the area of concha is curved? It is not straight. It's all like this. Can you see? So the air which passes through, can you see? Yes?
Is it in the center?
Yeah, it is in the center of my right figure, my cursor.
Alright.
Okay, so that is the lumen of your nasal cavity. So when air passes through, it doesn't straightly pass through. It passes through, it takes a turn, oh, somebody has got allergic reaction already. Yeah? Okay, because of respiratory system. So it passes through all these turbinate bones, so that the more the air is in contact with these areas, the more it gets warmed, humidified and cleaned. That's the purpose of this. Then we go to the olfactory portion. So the first thing we saw was a proper nasal fossa. We saw what is mucosa, what is the epithelium, what is the lamina propria. Then we also saw what is the submucosa and what is the external serosa adventitia or connective tissue layer. A little bit of modification is present in your conchal area just to have a lot of venous plexuses to humidify the air. The third and the last part of the nasal cavity would be your olfactory portion. Olfactory is receptors of your smell. So it is usually present in the roof and upper part of septum and the lateral wall of nasal cavity. It's always on the roof. It is never on the side of the nose. In a live person, if you're going to put light or put a scopy and see your olfactory epithelium, it appears yellow. It appears yellowish in color. So what is the epithelium here? It is lined by same pseudostratified, but the cells are taller. So it is lined by tall pseudostratified columnar epithelium without goblet cells. Why no goblet cells?
Because mucus can block the nose from smelling.
Yes. Mucus is actually a very thick secretion which can sit on the nasal olfactory epithelium, and then you cannot feel the sense of smell, especially in your flu-like conditions. That's the reason. Good. So it does not have goblet cell. And why doesn't it have a good basal lamina? It should have a good basal membrane, right? Or basement membrane. Why doesn't it have a good basement membrane? So what is the function of this? It takes in the sensation and it has to pass through the bone to reach the brain. So it doesn't require a basal lamina because all the cells are connected, are nothing but neurons. They will be connected to their cell bodies and then they will take the sensation. So I will show the next slide why it does not have a basal lamina. It has non-motile cilia on the surface because they are actually hairs, olfactory hairs which take the sensation of smell. They don't move anything, so they are non-motile. So when you look at the figure down on the right side, you can see an area of Bowman's glands in the lamina propria. Bowman glands, they secrete serous or watery fluid. Why do you have to have the serous or watery fluid in the olfactory epithelium? I think the explanation is given here.
Yeah, it's to wash out the solvents.
So if I smell a very bad thing, if I don't have serous glands, automatically the smell is actually sticking onto my nose for a longer time. If I smell a sampa or a dustbin, after 15 minutes also I will have the smell in the nose if there are no Bowman's glands. So the constant smell is washed away by this secretion of the Bowman's glands or the Bowman's serous glands. So serous means the secretion is very watery. It is unlike mucus or very thick. So when I look at the olfactory portion, it is in the roof. It appears yellow. It is a tall pseudostratified epithelium, but they don't have goblet cells and they don't have a nice basal lamina. They have cilia, but they are non-motile because they have to carry the sense of smell. They don't need to move anything. And the lamina propria has got a lot of watery glands, that's serous glands that usually secrete serous or watery fluid that can remove the odoriferous materials. So I'm going down further. So a comparison between the respiratory epithelium and olfactory. So respiratory, if you see, look at the height of the epithelium, look at the olfactory. So that's why I call it as tall pseudostratified epithelium. They are still pseudostratified, but they are very tall because they are not epithelial cells. They are actually modified neurons. So the epithelium appears thicker than the respiratory epithelium and has got three types of cells. The principal cells are your olfactory cells where you smell. So they are receptors. They are replaced every 30 to 60 days. They are bipolar neurons. What do you mean by bipolar?
They have two endings.
Yeah, don't tell me they are maniac and they are depressed. That also has two endings. It's actually two. Yeah. So these bipolar neurons is actually this one. I can show you this figure here. Okay, this one is easier. So look at the right image on the right side. The blue dots are your odor molecules. So here this yellow cell is actually your bipolar cells or your olfactory cells. So this olfactory cells, at the tip of it is forming a nice bulb-like structure. We call it as olfactory bulb. From there you have hairs or structures coming out. That is your olfactory hairs or olfactory cilia, which are non-motile cilia. So all the odor molecules they will receive the sense of smell from the odor molecules. Then it will pass through the dendrite. Then it will pass through the cell and then go to the axon. When it goes to the axon, can you see the axons are actually basically passing through the basement membrane. So they have to pierce the basement membrane and then only go to the brain. So since they all have to go pierce the basement membrane, they do not have a distinct basal lamina. So once they pierce the basement membrane, they will pass through the cribriform plate of your ethmoid bone, and you can see it directly goes to the olfactory bulb of the brain. So here this olfactory cells are nothing but bipolar neurons. The dendrite is facing the nasal cavity. The axon is carrying the sensation to the brain. Am I clear?
Yes,
Yes,
doctor.
teacher.
Okay, yeah? So that is your olfactory cells. Always when we have nerve cells, we need supporting cells. Like for example, your neurons are supported by astrocytes, by your generally glial cells, ependymal cells, astrocytes. Then you will have what else you have? Oligodendrocytes. So all these glial cells, they will support your neuron. Here, the cells that support your olfactory cells are called as sustentacular cells or supporting cells. They are also tall, slender. They have apex is broader with microvilli. The nucleus is actually placed centrally and superficially than olfactory cell. That's why it looks pseudostratified. So this one has a lot of lipofuscin secretory granules. So this lipofuscin secretory granules are used to digest all your foreign material. So this appears yellowish in color, and that's the reason the nasal mucosa has a yellow color. So if these cells die, they have to be replaced by a cell. So that's your basal cell. So basal cells are small. They are present only towards the base of a basement membrane, and then they will replace your sustentacular or olfactory cells. Am I clear?
Yes, doctor.
Yes.
Okay, so when I go to the nasal fossa, I have 5 different types of cells. In my nasal fossa, my function is to clean, warm, humidify the air. So for that, I have columnar cells with cilia, I have goblet cells, I have brush cells, granule cells, and stem cells to replace any type of cell. When I go to my olfactory cell, my function is to take my sense of smell. So I have olfactory cells supported by my sustentacular cells, and the stem cell of both is the basal cell. So if you're here to remove for my respiratory epithelium, I want to have a thick mucus so that it will attach itself to the foreign body and help it to remove. Whereas in my olfactory epithelium, I just want to remove the sense of smell, so I have thin serous glands of Bowman. So that's the difference between how the function will determine the structure. So then the next part will be the paranasal sinuses. How many paranasal sinuses do you have?
4.
Okay, so we
Pass.
have a pair of frontal, we have ethmoid, then we have sphenoid, then we have a pair of maxillary. So these paranasal sinuses are also lined by the same respiratory epithelium, but very few goblet cells. Why very few goblet cells? And also very few glands in the lamina propria. Why?
Otherwise, it's gonna cause sinusitis.
Yes, generally itself we have sinusitis, but then here if we have more gland secretion, it will secrete more, and the draining of the paranasal sinuses becomes difficult. So which is the sinus which is more difficult to drain of all the sinuses?
The frontal.
Frontal. I thought frontal is above and the drainage is below, easy to drain.
Maxillary, is it?
Maxillary. Maxillary is the one below your cheekbone. So that sinus, the opening is there on the top. It has to go and open into the lateral wall of the nasal cavity. So it is against gravity. So it's very difficult to drain a maxillary sinus. That's why the same structure is there as in the respiratory nasal mucosa. The only difference is the secretory goblet cells and the seromucous glands are very less. That's the only difference. Again, it's also due to the function. What is the function of paranasal sinus?
Just to make your head lighter.
Yeah, you reduce your head weight. Yeah, that is one thing.
As faces.
No, it once makes the skull lighter, yes. Number 2, it also warms and humidifies your air. That's why when you have your flu or sinusitis, your voice becomes very different. Your phonation becomes very different, and the warming or the humidification of air also becomes a bit difficult because the paranasal sinuses do not act. So do we have paranasal sinuses at birth? How is the fetal skull and how is the adult skull? Do we have paranasal sinuses at birth?
No.
No, we don't have paranasal sinuses at birth. That's why the fetal skull is very short and it's very short looking. When you compare it with an adult skull, we develop the paranasal sinuses and then we develop the mandible very well. So the features automatically change. So in babies, they ask us to take a passport every 5 years. For us, they give passport for 10 or 15 years because our face does not change that much. But for babies, they keep on changing because of the development of paranasal sinuses and the jawbone. So that's why the facial features change. Okay, it's just to add on. So I'm going to next to the pharynx. So the pharynx, as I mentioned, is a continuous cavity and subdivided into 3 regions. So the blue area is your nasopharynx, then again the blue area is your oropharynx, and the green area is your laryngopharynx. So only the nasopharynx is lined by respiratory epithelium, which is pseudostratified ciliated columnar epithelium with goblet cells. That's the full term you're supposed to give if we ask you for a respiratory epithelium. The middle and inferior belong to the oral epithelium. So they are lined by non-keratinized stratified squamous epithelium. So why is it non-keratinized? So where do you find keratinized?
Skin.
Only in the skin you will find keratinized. All other areas you will find only non-keratinized stratified squamous. So area of wear and tear, wherever you're going to eat your KFC and all the bones and you're scared your mucosa will get hurt, there you will have non-keratinized stratified squamous epithelium. Where else do you have this epithelium? Non-keratinized stratified squamous. Apart from your oral cavity, apart from your GIT. In your GIT, where else do you have? Oral cavity you have. The food then goes into the pharynx, you will have this epithelium. Where else?
Other than GIT, is it?
No, in the GIT itself.
Esophagus.
Yes, esophagus. Then? So in GIT, the entry and exit portions are lined by this epithelium. So the anus. So automatically when we eat, the food is very rough and tough. So the epithelium can undergo wear and tear. So up to the esophagus, you have this epithelium. By the time you digest the food, the fiber, everything, you reduce the water, you reabsorb all the water from your food. The feces becomes very hard. So the anus also has this epithelium. Apart from this, 2 other structures in our body have this epithelium, which is the cornea. Cornea is exposed to all your dust and all these particles, number 1. The second one is the vagina or the birth canal, where the baby has to be born. So that also is constantly subjected to wear and tear. So you will have non-keratinized stratified squamous epithelium. Okay. So we are just concentrating only on the nasopharynx. So this is lined by the respiratory epithelium. The lamina propria has dense, irregular connective tissue. It has got a lot of connective tissue. It has got mucus, serous, mucus, the same thing. But here, the lymphoid nodules are collected as nodules, or they group together as adenoids, or we call them as pharyngeal tonsils. This is a component of MALT. MALT means mucus-associated lymphoid tissue. So it's wherever the mucosa is there, wherever it's opening to the exterior, you will have aggregation of these lymphoid follicles. We call it as mucus-associated lymphoid tissue. If it is found in the nasopharynx, we call it as adenoids. What if it's found on either side of your tongue? What do you call it as? Have you heard of it? You call it as tonsils, right? If you open your mouth, you
Yes.
see two large groups of collection of lymphoid follicles. You just call it as tonsils. But here we give a special name. We call it as pharyngeal tonsils because present in the pharynx. So here, this pharynx also has a lot of connective tissue. I mean, which is fused with the connective tissue of the skeletal muscle. So the nasopharynx is also the same structure, lined by respiratory epithelium, has a lamina propria with glands. The only extra addition here is the presence of adenoids or your pharyngeal tonsils. Going down to the next layer is submucosa. You will have loose areolar connective tissue. Here I told you, as I mentioned to you, pharynx is a component of your GIT. So it will have an extra coat, which is a muscle coat. So this muscle coat will have an inner longitudinal and outer circular skeletal muscle layer. So the salpingopharyngeus, the whatever pharyngeus muscle you have it over there will all form the muscle coat, and the last layer will be your buccopharyngeal fascia forming your connective tissue. So your respiratory epithelium, yes, it is lined by respiratory epithelium. It has got a lamina propria full of glands and lymphoid nodules. It has a submucosa, Since pharynx is a part of GIT, it will have a muscle coat because your GIT is mainly function not only to absorb your food but also to propel the food. So you need muscle to push the food downwards or the peristaltic action. So pharynx has this one extra as the skeletal muscle layer and then the adventitial layer or the connective tissue layer. Clear?
Yes, doctor.
Okay. So when I see the difference between a nasopharynx and the oropharynx, oropharynx I'm not going to touch now because you see I just wanted to show the difference in the epithelium. Nasopharynx lined by respiratory epithelium on my left side. I can see pseudostratified, ciliated with cilia, columnar cells with goblet cells. When I look to the oropharynx onto the right side, I can see stratified, squamous, non-keratinized oral epithelium. So the epithelium changes. Nasopharynx is respiratory, oropharynx and laryngopharynx is your oral epithelium because the function changes. Larynx, do you want a break? I can give you only 3 minutes. Bolaya. Stretch yourselves.
Yes, doctor.
Okay, thank you. Just come after 3 minutes. Okay, I'm just continuing. So what we saw until now was that we finished our... Can you hear me? Are you in? Is anybody in?
Yes, doctor.
Okay, okay. So just a recap of what we went through. We went through the nasal cavity. For the nasal cavity, we saw the function was to warm, humidify, and as well as for sense of smell. For those functions, we have the respiratory epithelium with lamina propria and glands, which has a lot of lymphoid tissue. We also have a submucosal layer with glands and nerves, and then we finally have a adventitial layer. The modification of this epithelium a little bit with more venous plexuses is found over the lateral wall in the area of concha. You go to the roof of the nasal cavity, that function is olfaction, so we have bipolar neurons with supporting sustentacular cells and basal cells. When I go to nasopharynx, there is collection of lymphoid tissue and the structure resembles a GIT. So we have an extra muscular layer for the pharynx. So the next would be the larynx. Larynx is otherwise called as voice box. So it is made up of mainly a lot of cartilages, hyaline and elastic cartilage. It is made up of ligaments that connect the cartilage and skeletal muscles that help move the cartilages. So for the larynx, we are just going to discuss only about the epiglottis. I'm not going to go for thyroid cartilage, cuneiform, cricoid, arytenoid, no. We are just going to see the structure of an epiglottis. So what's the function of epiglottis?
Is to prevent from your food from going to the wrong hole.
Yeah, so epiglottis is basically, you will usually have, it is a tongue-like cartilage. It is actually moving, it moves a lot. So whenever we are tending to breathe in air, it opens the tracheal or the laryngeal opening for the air to let inside, or whenever we are speaking. Whenever we are eating, it will close the anterior part or the airway and open up the pharynx. So laryngeal, this epiglottis is quite movable. So since it is movable, it is formed by, the core is formed by elastic cartilage, which gives it more. It should be firm, but it should be movable. So that's why we have a elastic cartilage. So this epiglottis, again, it has got two surfaces. One surface which faces the oral cavity and one surface which faces the respiratory area. So whatever faces the oral cavity is lined by stratified squamous non-keratinized. So if you look here, so it's actually a tongue-shaped structure. The core or the center, it is lined by your, it has the elastic cartilage, whereas the anterior surface, I go here, I go down, my cursor is down. So that area is lined by your oral cavity epithelium, which is stratified squamous non-keratinized. So most of the anterior surface and a part of the posterior surface is lined by this. The other half, I go up, it is lined by the respiratory epithelium. Below the epithelium, we will have lamina propria with glands and lymphatic tissue. I go down further, core is formed by elastic cartilage. Have you ever heard your grandmothers telling not to talk when you eat?
Yes.
Yes.
Yes, sir. That's because your epiglottis will get confused whether to open your trachea or to close your trachea when you talk. So the instructions when you eat is close the tracheal opening, open the pharyngeal opening so that food goes into esophagus. When you talk, the epiglottis will not be able to close both orifices. So food enters your airway and then you will choke on your food. So that's the reason they ask us not to talk while we eat. But do we listen? We don't. Yes. So again, I repeat. So epiglottis is, yes.
Can you point out the anterior and posterior surface again? I think the cursor
Okay.
wasn't moving.
Okay, this one is the one which is below. Now the cursor is the anterior. I will show you more in the practical session. I should be showing you more in the practical session because this image is a very low power image. In the practical session, I will bring out more images that will show you what is the respiratory and what is your oral side. Okay, so now the cursor is on the oral epithelium side and then the above it is actually the respiratory side. How do you identify the difference? So actually in the lab, if you're there, I would explain to you. Usually we see the oral epithelium first. We run through the oral epithelium. The moment we start seeing goblet cells, that's where the transition becomes to the respiratory epithelium. So here you will have oral epithelium on one side, respiratory epithelium on the other side, and the center you will have elastic cartilage. Is it okay? I will show you more during the practical session.
All right, thank you, doctor.
Okay, yeah, on Friday. So then from the epiglottis, we move on to our trachea. So trachea is continuous with the larynx. It terminates into two main bronchi. The termination of trachea into bronchi is known as
Carina.
carina. Carina. Okay, carina or carina. Okay. So this is also made up of three layers because it is a respiratory part. So you have mucosa, submucosa, and you have adventitia. So now number one, I'm going to the mucosa. So mucosa is, so the features of the trachea is, it is lined by respiratory epithelium, the same. It has a C-shaped hyaline cartilage. So trachea is a cartilaginous tube which you have, which the cartilage we call it as tracheal rings. Okay, it is forming like a ring. Anteriorly, you will have a cartilage. Posteriorly, it is replaced by smooth muscle, or we call it as trachealis muscle, and fibroelastic tissue fills in between the spaces between the ring. So in this figure, you can see anteriorly you will have C. C is the cartilage. Posteriorly, you go down, you just have only smooth muscle and you will have fibroelastic tissue T. So that will help to increase or decrease the size of the cartilage. Why do you have cartilage in the walls of trachea?
Prevent it from collapsing.
Yes, we need, as I mentioned to you, we need to keep our airways open. And this airway opening and closing should also be regulated. If it's a bone, it is very difficult to maneuver your airway tract. Okay, because it's not only for air, this is for phonation as well. So you're going to talk, so automatically you need to maneuver your cartilage. So that's why we don't have a bone, but we have a cartilage. So the mucosa again lined by respiratory epithelium, the same thing, pseudostratified ciliated columnar epithelium with goblet cells. Lamina propria, same fibroelastic tissue with glands and lymphoid tissue. Here you will have an elastic lamina that separates mucosa and submucosa at the layer. So what are the cells that forms the epithelium? We'll go down further. So submucosa, again, it has got connective tissue, mucous glands, serous glands, lymphoid tissue, and a very good blood and lymph supply. So adventitia is made up of the C-shaped hyaline cartilage. So if I go to this figure, the M represents your mucous layer, epithelium, along with your submucosa. The C represents your adventitial layer or your cartilaginous layer, which posteriorly is replaced by the trachealis muscle. So this is the histological structure of the trachea. So it is the same as your respiratory system, only that the adventitia, you will have a C-shaped hyaline cartilage. When you look at the transverse section of a trachea and esophagus, esophagus is collapsed. Trachea is open. So meaning that breathe more, eat less. But do we do that? No. We eat more and breathe less. So the trachea, this is just to show that how the cartilage keeps the airway open. So what forms the cells of the tracheal epithelium? I think we already saw the ciliated columnar cells in your nasal mucosa. We saw the goblet cells also in your nasal mucosa. The basal cells are stem cells present in the nasal mucosa. Brush cells are basically, you will have the general sensation cells. The additional cells is serous cells. So trachea is an area where you not only have mucus secretion, but also you will have serous secretion. Okay, so that's why usually present. So the next cell, which I said, the granule cells, which belongs to the DNES or Apud or Kulczycki, same. They're all the same names. So this is otherwise called as amine precursor uptake decarboxylase cells. These are developing from the neural crest cells. So why is it called as neuroepithelium or pulmonary neuroepithelial bodies? Is because these cells, they will receive the sensation from the lumen, but they are connected to the nerve or sensory nerve endings below the basement membrane. So here, if there is hypoxia, if there is a foreign body in the lumen, automatically these cells will be stimulated. They will secrete granules or they will secrete their endocrine secretions from the granules in the basal cytoplasm. So these cells are more of endocrine in nature, and this will control the activities of goblet cells, the glands, and ciliary activity as well. So they also regulate the airway growth. So airway caliber, sorry. So, and as well as the epithelial cell growth. So why tracheal epithelium is pseudostratified is, again, you have the ciliated 30% of cells, goblet 30% of cells, basal cells 30%, brush 3%, serous cell 3%, and 3 to 4% of this small granule cells. So the tumor of these small granule cells is otherwise called as small cell carcinoma of the lung or oat cell carcinoma of the lung. Very difficult to treat. You know, there is these type of cells are also found in the GIT. You know, there's an actor called Irfan Khan in India. He passed away this year. He acted in that movie la, in the boat with the lion. Simple. I forgot the name of the movie also.
Life of Pi, Doctor.
Life of Pi. See, my mentee is coming for a movie name. Yeah, that's my mentee la. Okay, so he had this small cell carcinoma. So he had, that's why when they told the diagnosis 2 years back, I was like, difficult to treat because it comes from neural crystals and it can affect anywhere. You know, neural crystals, they are everywhere. So it's very difficult to treat them. So these are called as neuroepithelial bodies because they are in the epithelium, but they're connected to the nerve ending. So that's why we call as neuroepithelial bodies. So we finish the trachea, we go to the bronchial tree. So the bronchial tree, you divide it into pulmonary bronchus or primary bronchus. Then once you divide it into pulmonary bronchus or primary bronchus, the secondary and tertiary will automatically enter into the lung. So once they divide into tertiary, the other we divide, the tertiary will divide into terminal bronchioles and respiratory bronchioles. So just look at the bronchial tree image. We finished the larynx, which is we just saw the epiglottis in the larynx. Trachea, the line ones are called as the cartilage. So the C-shaped cartilage, anteriorly you have cartilage, posteriorly you have only trachealis muscle, divided into two main primary bronchus. This primary will again divide it into lobar and the tertiary, which is present inside the lung. So once they divide into that, they will divide into terminal bronchioles and respiratory bronchiole. Up to terminal bronchiole, it is still conducting portion. Once we give the name respiratory, the function becomes gaseous exchange. Okay. Put a table for you to see the difference between the primary, secondary, tertiary bronchus. Primary is similar to trachea. That's all. Only the diameter is small. That's the difference. That's all. So if you look at a trachea in the microscope, if you look at a primary bronchus in the microscope, you will not be able to tell any difference because it is the same. Only the diameter is smaller. So that is done. Let's go to the secondary bronchus. Again, smaller diameter, thinner walls. Here they will start having a lot of smooth muscle. So here there is a folded appearance in the mucosal layer because of a lot of smooth muscle. So the epithelium here is lined by pseudostratified ciliated with few goblet cells. Why few goblet cells?
You don't want to restrict the airway.
Yeah, you don't need to have goblet cells because you don't need any more secretions. All your secretions to remove all your substances is present up. Here we are going to transition into a respiratory portion. The conducting is all slowly reducing. Now we are going into a respiratory portion, so we don't need a goblet cell. And the height of the epithelium decreases. So columnar epithelium is not tall columnar, it is a bit short columnar, looks more like cuboidal. Because by the time we go to respiratory side, we have to become squamous. So when we want to become squamous, so the height of the epithelium starts decreasing. Lamina propria has got smooth muscle which is spiraling in opposite direction and elastic fibers. So when you have bronchospasm, the spasm affects this smooth muscles. So when we tell a patient has bronchospasm, has asthma, automatically you should think in your mind, where is the smooth muscle to cause spasm? In my bronchus. So when you give salbutamol to relieve the bronchospasm, you're acting basically on the bronchus. Am I clear? Am I clear? Yes?
Yes.
Yes, sir. Then we go to the submucosa. Submucosa has quite a number of glands and more lymphatic tissue. So this lymphatic tissue, we call them as BALT. or mucus-associated lymphoid tissue becomes bronchus-associated lymphoid tissue. They are aggregation of lot of lymphocytes here. And the cartilage slowly breaks. It will form irregular plates of hyaline cartilage. So when I look at a bronchus epithelium, look at the mucosal layer. It is a bit contracted because of the smooth muscle. It is something like an elastic. Your smooth muscle acts like an elastic. So there is curving of your epithelial layer. The cartilage starts to break. So why does the cartilage start to break? Do you need cartilage in your lung?
No.
No, you don't need cartilage in your lung. You don't, because your lung should be expanding and contracting like, because it's airway organ, right? I mean air exchange organ. So you don't need cartilage. So the C-shaped cartilage starts breaking and finally it will disappear by the time it is present deeper into the lung. So when I give an image like this, even this also, I wouldn't be able to tell whether it's a trachea or it is a bronchus. Only when I look at the epithelium, the height of the epithelium is less. I have smooth muscles forming a contracted appearance of the mucosa. I have numerous serous glands and mucus glands in the submucosa, and I have broken plates of cartilage. So when I see this, I might think it is either a secondary bronchus or a tertiary bronchus. Otherwise, the structure is very much similar to that of trachea. Am I clear?
Yes.
Yes.
Yeah. So the clinical correlates here is smoker's cough. Smoker's cough is because of the lot of particulate and gaseous pollutants in the airway. So automatically when there is nicotine going inside, when the person is vaping or a lot of particulate matter is going inside, your body will tell the goblet cells to secrete more mucus to remove, keep on removing. But what happens is these toxins in the nicotine or in the cigarette smoke, they will reduce the number of ciliated cells or they will cause destruction of the cilia. So what do you have now? Too much of secretions with lot of nicotine in it, no cilia to remove it and for you to spit out or for the patient to remove it from the nose. So it is all staying there. So when it stays there, automatically there is congestion of airways and the patient starts coughing. So that is called as smoker's cough. So a smoker will have more particulate particles in his airway. He will have no cilia, no ciliated cells, but a lot of mucus. How to remove it? By coughing. That's why he keeps on coughing. So initially, the cilia can be replaced. Once he stops smoking, you will replenish because your cells will automatically, your basal cell will produce new cells. But a chronic smoker, very difficult. He ends up having either COPD or goes in for a change in the epithelium and tumor. So once we finish the bronchi, we are going into bronchioles. So look at the epithelium first. Initially, I put it in brackets pseudostratified because it becomes shorter and shorter. So when it becomes shorter, the epithelium looks columnar. So columnar epithelium with goblet cells, then ciliated columnar epithelium with fewer goblet cells, then again ciliated low columnar or a cuboidal epithelium. These goblet cells are replaced by a cell called as Clara cell. So when I look at the lung, the bronchi in the lung, you can see the bronchioles are already inside the lung. The lung tissue is there beside it. So the epithelium looks more plain columnar or looks like plain cuboidal with Clara cells. So what are the Clara cells? So they are non-ciliated cuboidal cells. So these Clara cells are basically replacing all the epithelium of your respiratory tract. So they will have a lot of secretory granules which are present with dome-shaped apices. They produce more watery secretion like your serous cells, and it protects your bronchiolar epithelium. Plus, it also produces surfactant-like substance and maintains the patency of bronchioles, and they also can function as stem cells. So when you go down from the nasal tract, you go down to your bronchiole, you will not have a pseudostratified. So you don't have cells, 6 types of cells to produce each for every function. There is only one Clara cell which covers all your functions, which is production of surfactant, production of watery secretion, and formation of other cells, so it forms like a stem cell. So since all the cells look of the same height, either we say it is a simple columnar or simple cuboidal, no more pseudo stratified. Am I clear?
Yeah.
Okay, yeah?
Yes.
So what will be in the lamina propria? No glands. The moment you go inside a bronchiole, in a lung, you will not have any glands. You will have only elastic fibers and a lot of smooth muscle fibers. So this is where your bronchospasm also affects. So when a patient comes in with asthma, you know, okay, this patient has bronchospasm. Where is the spasm? In the bronchioles and in the bronchus. So automatically we tend to give bronchodilators like ipratropium bromide or salbutamol to dilate. Where is it acting? It is acting on the elastic fibers and smooth muscle fibers in the bronchiole and in the bronchus. So asthma is not a disease of the conducting portion. Asthma becomes a disease of more of the respiratory area, because that's where it's actually a transition between your conducting and your respiratory area. Am I clear? Yes?
Yes.
Yes, doctor.
Okay. So then we go down further to terminal bronchioles. So this image, you can see a terminal bronchiole. Look at the wall of a terminal bronchiole. It is thick, it is continuous. By the moment it goes into respiratory bronchiole, the wall is broken and many alveoli starts opening. So this is the transition between your proper conducting portion and your respiratory portion. So with terminal bronchioles, your conducting portion is terminated. That's all. So this is lined by ciliated or sometimes non-ciliated simple cuboidal cells with Clara cells. You have some brush cells and neuroendocrine cells here. Lamina propria, you will only have smooth muscle, connective tissue, and you will have your elastic fibers. So this is your terminal bronchiole. Once you finish off with your terminal bronchiole, you move into your respiratory bronchiole, or you move into your alveolar duct and alveolar sac. What are the changes in the conducting portion as we move towards the respiratory portion? So in your conducting portion, the height of epithelium is high, but when you go to the respiratory portion, the height of epithelium reduces. So where that is pseudostratified ciliated columnar, here it becomes squamous. Up to the level it becomes columnar, cuboidal, squamous, totally flattened. Goblet cells decrease in number and then completely disappear. Glands in the submucosa decrease and disappear. What increases are only two: elastic fibers and smooth muscle fibers. Cartilage also decrease and disappear. So in your conducting portion, height is very high of the epithelium, more goblet cell, more glands, more cartilage, because you want the airway to be open, you want to humidify it, you want to warm it, you want to secrete a lot of mucus to protect your airway. When you go to your respiratory portion, you want a flattened epithelium just for gaseous exchange. You want elastic and smooth muscle fibers to maintain the caliber of your airway. Just because only elastic and smooth muscle can expand and it can contract. Like when you inspire, it is expansion. When you expire, it is a deflation. So for that you need elastic and smooth muscle fibers. So that is the changes you would see. Clear?
Yeah.
Okay, yeah? So next we go to our respiratory portion. So this respiratory portion has respiratory bronchioles, alveolar ducts, alveolar sac. So the conducting portion, we finished our nasal cavity. Then we went to the olfactory area of the nasal cavity. We finished the nasopharynx. We finished the epiglottis or the larynx. Finished the trachea, the primary, secondary, tertiary bronchus. Then we finished the bronchioles up to terminal bronchioles. Now we are going to respiratory portion. In the respiratory portion, we have respiratory bronchioles, alveolar duct, alveolar sac, and the alveoli. So respiratory bronchioles, it is just lined by simple cuboidal epithelium. So here in this image, if you look at terminal bronchioles, the wall is represented by orange color. Look at the wall. The wall is more continuous. When you look at respiratory bronchioles, the orange color is broken. So meaning the wall starts breaking and alveoli starts sprouting. So that's where you know it is we are starting to have gaseous exchange in those places. So this wall is interrupted by sac-like outpouchings for alveoli for gas exchange. So this cuboidal later becomes squamous epithelium, and then once they start branching, the number of alveoli becomes increased. So coming down to the alveolar sacs of alveoli, you only have the alveoli, you don't have a proper wall also. So when we ask what is lined respiratory epithelium, just simple cuboidal, the wall is discontinuous. Why? Alveoli start opening into it. So we have a terminal bronchiole onto the right side, onto the right figure, terminal bronchiole, giving rise to respiratory bronchiole. Then we have ducts or alveolar duct, and the small area is the lung alveoli. So the lung alveoli is basically one small area. If I can just put my cursor there, can you see my cursor? The red color onto the right figure.
Yes.
So that is one lung alveolus. That is one alveolus for you. Okay. So you can
It's the
see
colorless, doctor.
red color cursor.
I mean the alveoli, lung alveoli.
Yes, it's only air.
Oh,
These are
alright.
all your air passages. So the air moves from the terminal bronchiole to the respiratory bronchiole. It goes to alveolar duct and it goes to finally one alveoli where gaseous exchange can take place. So then once we finish respiratory bronchiole, we go to an alveolar duct. So alveolar duct is again a discontinuous wall. Now the epithelium becomes simple squamous. So we started with pseudostratified ciliated columna, became simple columna, went to simple cuboidal. Now the epithelium already becomes simple squamous, a flattened epithelium. So in an alveolar duct, you can see many alveoli opening into the wall of an alveolar duct. Between these openings is where you will have collagen, elastic and smooth muscle fibers. It is also supported by thin fibroelastic tissue. So that is your alveolar duct. Actually, alveolar duct means it is one area where numerous alveoli open into. So if you see the figure below, you can see one alveolar duct. I'm putting my cursor on one alveolar duct. You can see many alveoli opening into it. That's all. That's why we call it as alveolar duct. It is also made up of only alveoli, but tumor, it's that many alveoli are opening into it. So always this epithelium is simple squamous, but it needs something for its support. That's why you have collagen, elastic and smooth muscle fibers for its support. Alveolar ducts will again open into 2 or 3 blind outpocketings we call as alveolar sacs. You see under microscope, you will not see a difference between duct and a sac. Lined by simple squamous, has collagen and reticular fibers as well as smooth muscle for its support. That's all. So this is just to see the structure, how it divides. So from terminal, we divide into respiratory. From respiratory, we divide into ducts and duct into. The microscopic structure is the same. Tumor, we just give names for the areas, that's all. So these alveolar sacs will open into a common atrium. For example, there is one, the figure you can see ALV, that is one alveoli, it is just opening onto itself. But ALV SAC means many alveoli are opening into one sac. Do you understand the difference? It is just that the opening is many alveoli. If they open together, we call them as alveolar sac. If just one alveolus is closed on itself, we just call it as alveolus. Can you see the difference? Yes, no?
Yes.
Okay, yeah?
Can you repeat, doctor?
Okay, if many alveoli open into a common atrium, into a common, so in this figure, it is called as ALVSAC, alveolar sac. So if you can see many small alveoli opening into that area, so we call them as alveolar sac. If one alveolus is closed on all its ends, we call it as a simple alveolus. Clear?
Oh, alright. Thank you, doctor.
Okay, it is just that the opening. Otherwise, you look at the microscope, alveolar sac, alveolus, everything has the same structure. It will just lined by simple squamous supported by connective tissue. That's all. So for the alveolus, you can just take another break for about 3 minutes and then you come back. Then we finish the lecture. Okay? Okay.
All right, doctor.
Doctor,
Yeah, Jonathan?
between each alveoli, all the white spaces, they are considered as connective tissue, is it?
They are
Or just
considered as air.
air?
Air only. Because this connective tissue is actually the cells. So in this figure, you can see the cells are there supported by connective tissue. That's all. The all of the whitish area is air.
All right.
Air spaces only. That's all.
All right. Okay. Thank you, doctor.
So can I continue?
Doctor,
Yes, doctor.
Yeah.
I
Yeah.
have a question.
Yeah, please.
So, respiratory bronchioles is lined by two epithelium, is it? Simple cuboidal and simple squamous.
No, respiratory bronchiole is usually simple cuboidal. Or
Yeah.
actually, it can either be. It actually in certain areas it is simple cuboidal, in certain areas it can become simple squamous. It depends. If the
So,
wall,
it,
like
it
for
changes
example,
from
I will
simple.
just show you the image now. Okay, so in this one, the areas where the orange ones are there, usually it is simple cuboidal. But when they start having these outpouchings, you can see the outpouchings coming out, their area it will have simple squamous. So both are correct. It can be simple cuboidal and simple squamous.
So it changes from simple cuboidal to simple squamous, is it?
Yes, yes. So the height of the
Okay.
epithelium keeps on decreasing for you.
Thank you.
Okay. So we go to the last part of the lecture, which is the alveolus. So alveolus is the structural and functional unit of your respiratory system. So these are small air sac evaginations or outpouchings for basically for gas exchange. They are lined by simple squamous cells. So the epithelium is simple squamous epithelium. You cannot have a columnar, you cannot have a cuboidal epithelium. Otherwise, there is no gaseous exchange in the air, in the lung. So in between the alveoli is where you will have an interalveolar septum. So in between two alveoli, though it might look as just only one alveoli, you will have a small septum in between. This septum has elastic fibers and reticular fibers. Plus, it will also have a few macrophages. Why does it have elastic fibers? So that you expand and elasticity, you will contract your alveoli. When you breathe in, the alveoli expands. When you breathe out, the alveoli, there is an elastic recoil. But you don't expand to the level of you just keep on expanding. So you need something to check the expansion. So that is the reticular fibers. So the reticular fibers will prevent the over distension of the alveoli in the interalveolar septum. So in the interalveolar septum, you will have openings or very small microscopic openings. We call it as alveolar pores of Kohn. This, why do you have alveolar pores? Meaning that the pressure in one alveoli should be equal to the pressure in another alveoli. So it maintains the gaseous pressure between the alveoli. It is nothing like one alveoli is so big, lot of air. One alveoli is contracted, no air, not like that. Through the pores of Kohn, air is equally distributed between the alveoli. Am I clear?
Yes.
Is it a? Okay. So now coming to the interalveolar septum. So this interalveolar septum are just areas where two alveoli meet. So this interalveolar septum can be either thin or it can be thick. The thin areas are usually used for gaseous exchange. The thick area is used for fluid distribution. It will have connective tissue cells and macrophages. Usually it has got very minimal fluid. So tissue fluid accumulated here in a normal person is drained by the lymphatic system. What happens in pulmonary edema? Since you have finished your CBS, I'm asking you this question. What happens in your pulmonary edema?
Your fluid starts to accumulate in all the
Yeah, you can
spaces in the
see
lungs.
in these images, you can see lot of capillaries, right? Alveolar capillaries. So this alveolar capillaries will have a lot of blood. The fluid will exudate and will collect in your thick region or your in the normal. So your lymphatic system cannot remove all the fluid. So there is a lot of fluid in your lungs. So when there is a lot of fluid, gaseous exchange does not take place. So automatically the patient goes in for respiratory distress. Is it clear now why they have respiratory distress in pulmonary edema?
Yes.
Yes, sir. So this is where the fluid get collected. So this is so when there is a distance between the capillary and the alveolar cells, automatically gaseous exchange cannot take place. So that's why we give them diuretics like furosemide. Furosemide makes the person urinate a lot. So in that process removes the excessive fluid. Okay. So what are the cells of alveoli? We know that they are simple squamous epithelium, but you have two functions for these cells, type 1 pneumocytes and type 2 pneumocytes. Type 1 pneumocytes are squamous or very flattened alveolar cells. Type 2 pneumocytes are a bit bigger. That's why we call them as great alveolar cells or septal cells. So in this figure, type 1 is the one which is shown as 1 and type 2 is the green cell. So though they appear squamous, type 2 is a little bit bigger, that's all. But still in a light microscope, what we have in our lab, we cannot find the difference between type 1 and type 2. We will just be able to see it only as a simple squamous epithelium. What is the function of type 1? They line the alveoli. They are permeable to gases. So they are totally flattened because air has to pass through these cells. So the cytoplasm will, it is actually a shape of a spindle shape like your smooth muscle cell. So the cytoplasm is towards the periphery and there is a tight junction present in between the cells so that fluid does not leak out. So if I ask you the cells for gaseous exchange, that they are type 1 only. not type 2. Okay. So why do we have type 2 cells? Type 2 are bit rounded or cuboidal. The number is more, but they will not line the alveolar surface because we need only type 1 for gaseous exchange. So what is the function of these cells? They produce pulmonary surfactant. So when you see the cells, you will have a lot of vacuolated cytoplasm, a lot of vesicles containing the pulmonary surfactant. What is the function of pulmonary surfactant?
Reduce the surface tension.
Yeah. What do you mean by reduced surface tension?
It prevents the collapsing force of the alveoli.
Okay. Okay. So for example, now I'm breathing in. When I breathe in, all my alveoli will expand. When I breathe out, the alveoli all will collapse. But this pulmonary surfactant will prevent the total collapse of the alveoli. It maintains a surface tension so that the alveolus does not collapse totally. So the next time I breathe in, my work becomes easier because already the alveoli are open a bit. So I just have to move more. That's all. Whereas when the pulmonary surfactant is very less, the alveoli it opens, but the moment we remove the air out, they collapse. So the next time I have to breathe in, I have to work very hard against a closed alveoli. So without a pulmonary surfactant, the patient can go in for respiratory distress. So plus this also degenerates as type 1 and type 2 cells. So in my lungs, I have two types of cells in the alveoli. Though both of them look like squamous when I look under a light microscope, but both will have the different function. Type 1 for gas exchange, type 2 to produce pulmonary surfactant. So when this is a nice picture, actually we can, if we look carefully into the microscope, we can find actually the difference between type 1 and type 2. In the above image, the type 1 cell, it looks totally flattened and it is near a capillary. You can see a type 2 cell which is a bit rounded because it has secretions in it. So that's the difference. And because the size is different because it has got a lot of secretions of pulmonary surfactant inside as vesicles. So that's why the size is a bit rounded. So what is surfactant? So it is produced by type 2 pneumocytes and released by exocytosis. It forms a network on the surface of the alveoli between the pneumocytes and the phospholipid film. So I think Dr. Atika would have taught you about this. When does type 2 cells mature?
24.
24 weeks lah. So if a baby is born before 24 weeks of age, very difficult for the baby to survive, for an infant to survive. So once a lady is going into labor, you are expecting a premature labor like 26 weeks or 27 weeks, we try to delay the labor by giving, and then we give them steroid injections. Steroids helps in early maturation of this pulmonary type 2 pneumocytes. So we give at least 2 doses of steroid 8 hours apart, and then we allow the lady to go into labor. Most of the time premature, they come to the ward with almost the head coming out, so we cannot stop that lah. But if we can postpone, we postpone to give corticosteroids to help the maturation of type 2 cells. So when they mature, the babies will have surfactant when they are born. Okay, so this helps to reduce the force necessary to inflate an alveoli to easy my breathing process. So coming to the premature infant, the surfactant, if it's very less, it leads to respiratory distress syndrome. So here we can give glucocorticoids, or I said steroid injections, to the mother for maturation of pneumocyte, or they will introduce synthetic surfactant into the lung of the baby so that they will have surfactant on their surface. Without surfactant, the baby goes in for respiratory distress syndrome because they cannot open their airway. That's the thing here. Okay. Another clinical correlate is about alveolar macrophages, phagocytes or dust cells. So we saw about type 1 cells, type 2 cells. Alveolar macrophages are not a permanent cell in the lung. They are in the bone marrow as stem cells, then they mature as monocytes and they will enter the interalveolar septum. whenever there is a need, like for example, I am swallowing, the bacteria or virus moves into the lung, or there is a dust inside the alveoli. So automatically these macrophages will become bigger. They will phagocytose the dust or the particulate matter, the nicotine or whatever. It will then pushed by the cilia, it will be pushed upwards. So it will induce a cough reflex. So here you don't have cilia in the lungs, so we'll start inducing a cough reflex. It will be brought up, then the cilia will help to either spit it out, or or if it's babies, they will just swallow the saliva. Once their function is over, they move back to the interalveolar septum and they will enter into the lymph vessel. So these cells are large. They are black in color usually because the phagocytose material gives this black color to the macrophages. Where do you find resident macrophages? Macrophages is constantly there. In which organ? Any idea? Macrophages are moving population. We also call them as transitory connective tissue cells. Where do they stay? Just to eat up all the bacteria and things. Any idea? No idea? What about your brain? What about the brain and the Kupffer cells of the liver? Huh? Hello? Are you there?
Yes, we're here.
So the macrophages are resident cells of the brain. In the brain as well as in the spinal cord, like in the neural tissue, we call them as astrocytes, or we call them as oligodendrocytes. And then oh no, not astrocytes and oligodendrocytes. Okay, in the liver we call them as Kupffer cells, whereas in the brain they are I forgot.
Is it microglial cells also?
Yeah, they are microglial cells. Yes, thank you. So the microglial cells in the brain or in the nervous tissue, as well as the Kupffer cells in the liver, these two are resident macrophages. They don't go back to the lymphatic system. Whereas in the alveoli, they travel back and forth. Unless and until there is a need as a foreign body coming in, they are not usually present there. So in a normal lung tissue, it's quite difficult to identify, but in smokers' lung, we can identify because they have a lot of nicotine in their lungs. Always they will be present as black cells, you can see there. Okay. The next would be your blood gas barrier. So when oxygen comes in to the lung, to the alveoli, the first thing it will meet is the surfactant. Then it will go into the alveolar epithelium or the type 1 pneumocyte. Then it will go through the fused basal lamina of the type 1 pneumocyte and the capillary, and then it will go into the capillary. The carbon dioxide will diffuse from the capillary, goes to the basement membrane, goes through type 1 pneumocyte, goes to the surfactant and goes out of the body. So that's how the blood gas barrier works. So number one, if oxygen comes in, it meets the surfactant, then it enters the cytoplasm of type 1 pneumocyte, goes through the basal lamina of pneumocyte 1 and capillary endothelium, and then goes into the capillary. So when there is fluid in the lungs, the fused basal lamina of this pneumocyte and capillary endothelium separates, and that's where the fluid enters. So when you have excess fluid there, so now if a patient has pulmonary edema, the oxygen will enter through the surfactant, go to the alveolar epithelium, then it has to pass through the fluid, then has to pass through the endothelial cell cytoplasm, and then only go to your heart. So it takes a lot of time to travel there. So that is why in cases of fluid in the lungs, the patient goes in for respiratory distress. Am I clear? Clear?
Yeah.
Okay. Yeah? So with that, I think we are done with the structure. We just now go in for the functions and clinical correlates. So the functions of the components of respiratory system. Vibrissae. What do you mean by vibrissae?
It's the long hair. Then.
Yeah, the nasal hair is called as the vibrissae. So this is used basically for filtering large particles. Then you will have a lot of mucus and serous secretion which humidified inspire air as well as trap large particles. Cilia, the function is to beat the sputum towards the pharynx where the mucus is expectorated or swallowed. Anything can happen. So from the nose, the cilia beat towards the mouth. From the trachea, the cilia beat towards the mouth. So the direction changes. Remember that. So from the nose, the cilia doesn't beat out of your nostrils. They beat towards the pharynx. They will push it down. From the trachea, they will push it up so that everything comes out through the oral cavity. So lymphatic tissue is for immunological defense. If you find cartilage, it's for to maintain the patency. Reticular fibers is to prevent over distension. Macrophages is to phagocytose particles. Elastic fibers permits expansion and recoil. Smooth muscle to control the diameter. And why do you have a cough reflex? To expectorate or swallow the trapped mucus. So that's why the patients have cough reflex. Is it clear? So whenever you see these structures in the respiratory epithelium, you know, okay, this is the why I have it. This is the function and that's why I have it. Is it clear?
Yes.
Okay. Yeah? So now coming to the clinical correlates. So for me, as year 2, it's very unfortunate that we are having an online class, so that it's very difficult for you to really organize your medicine is one single thing finally it ends in the human body. So whenever you read histology and histopathology, you read it side by side like this. So the above is a normal alveoli, below is alveoli in a congestive heart failure. So when you read histology and histopathology like this, automatically you would know like why these occur. So in a heart failure patient, the capillaries of lung become congested with blood and erythrocytes. In which heart failure, right or left heart failure, you will find this type of lung?
Left.
Yes, very good. In a left heart failure. Then they will pass into the alveoli and phagocytosed by the alveolar macrophages. So when these alveolar macrophages eat up the erythrocytes along with the fluid, and then if the patient dies, then we take a slide from the lung and stain it for hemosiderin pigment. The macrophages will stain brownish in color because of the iron content. So this we call them as heart failure cells. So the macrophages filled in with hemosiderin pigment identified as a post-mortem finding in heart failure patients is called as heart failure cells. Clear? Yes?
Yes, doctor.
Yeah, because normally erythrocytes and fluid shouldn't be a part of your lung tissue. It should remain within the capillary. But when there is excessive blood being pushed into your lung, they don't have a choice. They ooze out of the capillaries. So the macrophages will identify them and eat them up. So that's why they take up the hemosiderin stain. So what happens in pneumonia? This is basically, this clinical correlates I am giving you just for you to see the difference in what is normal and what is abnormal. In normal person, his capillaries of the lung is normal in size. There is no fluid in the interalveolar septum. So only air is in the lung. So the lung weighs light. You take a piece of lung and put it in water. Will it float or it will sink?
It should normally float.
Float it should normally float and there is a normal gaseous exchange happening. Whereas what happens in pneumonia, there is acute inflammation in alveoli. So your macrophages is there releasing a lot of mediators. So the capillaries will enlarge because they want to send all the macrophages and neutrophils to your lung to eat up all over the bacteria there. The exudates collect in the interalveolar septum. So whatever fluid is there in the interalveolar septum. So more exudates, the lung becomes heavier. So you put the lung inside water, it will actually drown. It will not float. This is because a lot of fluid is in there. So a longer time taken for gas exchange leading to dyspnea. This is what happens in COVID as well. In COVID, we do not know the virus because our immune system is totally oblivious to this new virus. So our inflammation takes over, it kicks over. It will release a lot of mediators from macrophages as well as neutrophils. So imagine the lung of a COVID patient, the capillaries are quite big. Too many macrophages and neutrophils will keep on secreting fluid. It is on a good intention. Our inflammation is to kill the virus. But and in that process, it will drown our lung in our own fluid. This is called as cytokine storm. This is what happens in COVID. And this is why the patient becomes breathless in COVID. The same pathophysiology like this pneumonia. Clear? Is it clear?
Yes.
So what do you treat these patients with? If a patient with COVID or pneumonia, imagine COVID itself, they go in for respiratory distress, what do you give them to reduce the inflammation?
Hydrochloroquine.
Yes, you give steroids. Hydrochloroquine
That
to
was what
reduce
was
inflammation.
that was
Initially,
initially.
that is
After
initially
that, they
la.
use
Now
dexamethasone.
now steroid is the only treatment they give. So basically, when a COVID patient comes down, they do an X-ray and see. In an X-ray, if they find a lot of fluid in the spaces in the lung, this is called as ground glass appearance. The lung is not black. It becomes whitish because of presence of fluid. It is called ground glass appearance. Once they see that, they do a CT. A CT will tell you where the fluid is, how much of percentage of lung is affected by these secretions. Immediately they put the patient on steroids. So initially they will look at the viral count. If the viral count is low, then only they give the steroid. If the viral count is very high, you give steroid, the viral count will become even more higher. So they give them remdesivir and then they give them steroids to reduce the secretions. So this is what the treatment is. So you see, this on the left side is a normal alveolus. On the right side, you will have alveoli full of fluid and cells. So a COVID patient or a pneumonia patient has a lung like this. How to have gaseous exchange in such a lung? So automatically the patient becomes breathless. Clear? Clear?
Yes.
Yes,
Okay,
doctor.
yeah. Continuing further, what happens in asthma? So normal structure and function, the smooth muscle of the bronchiole, when you breathe in, they relax. When you breathe out, they contract. So the goblet cells and the glands are all normal. In asthma, there is an inhaled antigen. Either it is a virus or it is a dust particle or any allergen which you are not used to, which you are sensitive to. It will combine with IgE in the surface of mast cells. So it will release histamine. So effects is the bronchioles will show vascular congestion, edema and infiltration by neutrophils, plus there is bronchoconstriction. Not only there is hypersecretion, there is also bronchoconstriction. So here the bronchioles become filled with secretion, plus they are all constricted. So you have to treat them with two things. Treat them for the inflammation, treat them for the bronchoconstriction. So here they will have, you have to give either steroids or you have to give to reduce the inflammation. For bronchoconstriction, you have to give them bronchodilators. So here, when the patient breathe in normally, but when they breathe out, the prolonged bronchocontraction will occur during expiration. So the size of the lumen decreases, and when the secretions are there and the size of the lumen is small, the movement of air within the secretion is what we hear as wheeze. So what is wheezing? The patient having bronchospasm plus lot of secretion. So the movement of air within the secretion produces your wheeze there. Am I clear?
Yes.
Yes.
Okay.
Doctor,
Yep.
for those that inflammation, you said that we give steroid, right?
Inflammation. Yes, we give steroid. Yes.
But how about NSAID? Can we give NSAID too?
NSAID is non-steroidal anti-inflammatory. Non-steroidal anti-inflammatory is to just to fight against your prostaglandins, right? It's for your pain mechanism. They do not help in all the mast cell stabilization, or they do not help in histamine or bradykinin and all. They do not help them. Only steroidal will help.
All right.
Okay, so when you want to target the prostaglandin mechanism, then you give NSAIDs. When you want to target your histamine, bradykinin, and those things, you have to give steroids. So here, if you see, we also give mast cell stabilizers. Have you heard of mast cell stabilizer? Which stabilizes the mast cell and they do not allow them to secrete more histamine. What is the effect of cetirizine here? Have you heard of cetirizine? Anti-allergic drugs?
It's an antihistamine.
Yeah, it is an antihistamine. So basically you're reducing your secretions. So it's actually a combination. So throughs, we don't give a steroid. We don't give them oral steroids. We give them antihistamine first. Then we try them with with inhaled, or we put them on nebulizer with steroids. And then if they don't respond, and then only we give systemic steroids. Steroids is not given immediately in a case of asthma. Okay. So here is a normal bronchus. You can see the epithelium, you can see the smooth muscle. Look at a bronchus in an asthma patient. There is a thickening of the epithelium because of too much of goblet cells and secretion. So there is bronchoconstriction. Smooth cells are also thickened out, and they will make the bronchus very narrow inside. So that's the difference between a normal patient and a patient with asthma here. Last part would be your emphysema. Emphysema is basically you will have normal leukocytes in your or WBCs, and also if you have any enzymes or proteolytic which removes the protein by antitrypsins. Emphysema is chronically seen in a smoker patient, who's a smoker. The lung is in a state of chronic inflammation. So we call it as pulmonary inflammation. So we have too much of neutrophils will secrete proteolytic enzymes. So these proteolytic enzymes eat up the alveoli. So they will cause breakdown of the alveolus. Plus, some patients will have alpha-1 antitrypsin deficiency, which cannot neutralize these proteolytic enzymes. So in these two conditions, in a smoker who produces more proteolytic enzymes, or in congenital patients who have this alpha-1 antitrypsin deficiency, too much of proteolytic enzymes is there, they will eat up all the elastic tissue. So when the patient breathes in, he can breathe in. When he wants to breathe out, he cannot breathe out because there is no elastic recoil. So his inability to push out carbon dioxide, unable to take in oxygen, and then ends up having dyspnea. So on to my right side is a normal lung tissue. On to my left is the normal lung tissue, where you can see the normal alveoli, normal size and shape. Go to the emphysematous lung onto the right side. You can see dilated, permanently enlarged airways. There is no elastic recoil because all the elastic tissue has been eaten up by the elastase enzymes. So this usually occurs in a smoker, very commonly in a smoker. They will usually have a barrel chest because the lung is quite big. They cannot go back to their normal shape. In a lung carcinoma, usually Dr. Bushra will talk about 3 types of cancers: squamous cancer, adenocarcinoma, or small cell carcinoma, or oat cell carcinoma. So if the bronchus goes in for a squamous metaplasia, changes, it's very common in smokers because constantly the patient is smoking, there is too much of nicotine in the airway. So the lung will think, okay, I need to build up more squamous epithelium for the wear and tear. So there is change into squamous metaplasia and forms squamous cell carcinoma. If there is a tumor from the glands, from the normal columnar epithelium, from the globular cells, then they will form adenocarcinoma. If there is a tumor arising from neuroendocrine cells or the small granule cells, they will form small cell carcinoma or an oat cell carcinoma. So whenever you read, this is just my suggestion to you, whenever you read your histopathology, keep your histology side by side. This is the normal structure. Where does it go abnormal? So in that case, it is easy for you to understand in that point of view. So the last one would be your pleura. So what is your pleura? What is pleura?
It's like a sac covering your lungs.
Yeah, something like your pericardium. So pleura it covers your lungs. It has two layers, parietal and visceral pleura. So visceral is the one which is lined by mesothelium. They will produce a lot of pleural fluid. Why do you need pleural fluid? Why do you need pleural fluid? Hey. Why do you have pericardial fluid?
Lubrication.
Same thing, pleural fluid.
Yeah.
Yeah, your lungs as well as your heart, both of it are constantly moving involuntarily. So to reduce the friction and to increase the lubrication, you will have pleural fluid secreted by these mesothelial or simple squamous cells. If the fluid becomes excess, then we call it as pleural effusion. If there is blood in the pleural space, we call it as hemothorax. If there is air in the pleural space, we call it as pneumothorax. And if there is infection in the pleura, we call it as pleuritis. Same thing as your pericardial effusion, or it can like your pericarditis, the same function. So in your heart it's called pericardium, in the lung the outer layer is called as pleura, and in the abdomen we call it as peritoneum. The name changes but the function remains the same. Am I clear?
Yes.
Okay, so this is the end of your histology class. I think Jonathan has already put in the attendance sheet into the chat function. Who haven't signed in your attendance, please make sure you have signed it. Any doubts in this topic? No doubts. All clear. Okay, can I leave the can I leave the class?
Yes, doctor.
Okay, thank you so much. So I will meet you back on Friday. Jonathan, can we start at 9 for the histology and the radiological components? Because gross, I think tomorrow Dr. Atika and Dr. Sara will cover. Okay, at 9. So through the same channel, I think there's a channel there. We can just go in there. And the histology lab guide, I think I need to add few more images last. So whoever has printed it, I'm really sorry. You can just add on the extra pages. Whoever is not, just wait for me until today. I will send you a new one. Is it okay?
All right, doctor.
Okay, yeah. Thank you so much. Assalamualaikum.
Thank you, doctor.
Thank you, doctor. Thank you, doctor.